There have been many advancements in the field of radiation oncology that will allow us to better customize the treatment for the patient. Your radiation oncologist is board certified in radiation physics and will design the therapy to give you the maximal chance of cure and the least risk of any side effects or late effects. Radiation is designed specifically for your size and shape and the location that we want to treat. For example, sometimes we treat lymph node areas and sometimes we treat the skin and sometimes we don't. Cancer cells are very sneaky and could be lurking in other areas around the cancer site region, so it's very custom designed. We also now modulate the length of the treatment, the dosage of radiation, and have improved targeting capabilities.
Treatments for breast cancer, fortunately, are now able to do more with less, so to speak. So we're able to deliver targeted therapies and not a one-size-fits-all sort of approach. We're able to parse out different types of breast cancer and tailor therapies to not only the type of breast cancer, but the patient, depending on their family history, their age, all sorts of other factors. And so treatments have become more effective while also being less toxic with fewer side effects. And it's because of advances in testing, technology, and more research and innovations that we've been able to have breakthrough over the past few years.
When deciding on what type of surgery a patient needs, there are a number of factors. First of all, family history is extremely important. We always ask people when they come in, do they have any primary relatives like a mother or an aunt? That sort of takes the utmost precedence. And if there's a family history, that usually leads to genetic testing. Genetic testing can typically tell us if a patient has a mutation or not. Patients that have mutations are at a higher risk for getting breast cancer, and then they will typically have mastectomies to prevent them from getting additional subsequent breast cancers. The other thing we look at for whether we can do a lumpectomy or a patient needs a mastectomy is imaging is super important, right? Small tumors are amenable to have tiny little lumpectomies. Bigger tumors have to have mastectomies. So probably two of the biggest criteria is family history, which goes in hand with genetic testing, and then imaging findings as well.
According to the American Cancer Society and Society of Breast Imaging, we are recommending that every woman age 40 and over of average risk gets a screening mammogram once a year, every year. Ideally, that is with 3D tomosynthesis imaging as well. 3D imaging is also known as tomosynthesis, is a type of mammogram and really a supplemental screening in itself to mammograms that we do that for every single mammogram that we perform at our facility. It is the latest technology, and it allows us to not only have a 2D image of your breast tissue, but also able to get a 3D image, which is going slice by slice through that tissue to improve our cancer detection rates. If anyone has an increased risk of breast cancer, whether that be due to a family history or genetic mutation or several other factors, in those cases, we sometimes will start screening mammograms earlier, beginning at the age of 30.
To prepare for reconstructive surgery, you have to think of it as sort of a team endeavor. I would lean on your family as well as your team of doctors throughout the whole process. Breast reconstruction is a very personal decision, and there are several options. It's important to be fully informed about all the options that are available to you, and then together as a team make the correct decision. Physically, you would like to be in the best shape as possible prior to surgery, and we involve your primary care doctor and try to tune up any of the comorbidities that you may have. For example, if you're a diabetic, we would love to get that under control. If there are certain things you can stop prior to surgery, such as smoking, that ensures the best outcome. Emotionally, I think it's important to lean on your family, and it's a good idea to understand the expectations, which your reconstructive surgeon will go into detail with you.
Once a patient gets diagnosed with breast cancer and we've made the decision to recommend chemotherapy, there's a series of steps that we go through with each patient to make sure they're fully informed and they have the safest journey possible. One of the things that we do is something called a chemo school, where not only the physician sits down and goes over all of the chemo drugs, how often we'll be doing it, the risks, the side effects, the benefits, and all of that. We have our chemotherapy school with our nurse who talks to the family and gives them sort of a playbook so that when they go home, they know what medications to take for nausea, what to take for other side effects, what temperature to worry about, what phone numbers to call during hours, after hours. So it's a really informed approach where they can sit and listen and then also ask a bunch of questions so that their journey can be informative and safe from start to finish.
There are multiple different categories for supplemental screening imaging, and one of those is for my high-risk patients. Anyone who is considered high risk for developing breast cancer, we recommend that they get a screening breast MRI as a supplement in addition to their screening mammogram. Another category is our patients that are not considered high risk but do have dense breast tissue. For those patients, we do recommend and offer at our facilities screening breast ultrasound as a supplement to an annual mammogram.
Not everyone needs radiation therapy. We utilize radiation when it can increase the chance of cure or reduce the risk of recurrence.
Family history is very important. It's one of the things that we ask on a first visit, try and get as much clarity and detail as possible. More and more, especially recently, we're learning how pivotal of a role genetic testing and inherited conditions play in breast cancer. Now we are running genetic testing on almost every patient that has breast cancer, because the more we identify cancer-related genes, the more targeted therapies and tailored therapies we can provide because of that information. Some women, unfortunately, breast cancer just occurs. 1 in 8 women will get breast cancer in their lifetime, so unfortunately it is fairly common. But some women with the stronger family history, it may be related to that. So we want to make sure we're not missing that piece of the puzzle. And again, there are guidelines in place about who we can test, who should be tested, and who it may not play a big role on depending on some of that information.
Typically, any patient that has an invasive breast cancer, so at least a stage 1A breast cancer, does need to have lymph nodes under the armpit evaluated. Those are called axillary lymph nodes. So any patient that has a breast cancer that's invasive does need to have at least what's called a sentinel lymph node removed, means the first draining lymph node. The sentinel node, we typically will take that out, send it to the lab while the patient is asleep, and just to check that the lymph nodes are clear and clean. If only one lymph node is removed, the chance of lymphedema from that is exceedingly small, less than 1%. If that lymph node that we check is involved, then obviously I have to remove more lymph nodes so that we're not leaving any cancer in the patient. And those patients typically have a lymph node dissection where anywhere from 8 to 20 lymph nodes are removed. Those patients also will typically get some radiation on that side, and their chance of lymphedema or arm swelling can be as high as 20%. So usually any of our patients that have lymph node removal in the setting of a full lymph node dissection, we usually send them to see some of our great physical therapists that help talk about the risks of lymphedema and prevention of lymphedema strategies.
You will meet with the reconstructive surgeon very early in your journey, usually just after the diagnosis and meeting with your surgical oncology team. Potentially, if you need additional treatment prior to surgery, you might get that, such as chemotherapy, before meeting your reconstructive team. Once you do meet your reconstructive team, the breast reconstruction is a very personal decision, and there are a lot of options. Our goal is to be your co-pilot through this process, help you make the best decision, and make sure you don't make a bad decision.
To patients that have a personal history of breast cancer, first and foremost, we recommend that they get their annual screening mammogram once a year, every year. And there are several different people that I would also like to get supplemental screening. Anyone who was diagnosed at the age of 50 or younger, I recommend that they get a supplemental screening breast MRI. The other patients that I would like to get a supplemental screening MRI on, and that is again on an annual basis, is any patient who's ever been diagnosed with breast cancer and has dense breast tissue. This is really a conversation between you and your breast surgeon about what is best for you, because oftentimes they will also recommend supplemental screening ultrasound for patients as well.
Our younger patients that get diagnosed with breast cancer, one of the primary concerns and things that we talk about with upfront before we start any form of treatment is the effect on their hormones. Younger premenopausal women, depending on the type of breast cancer and the type of therapy that we recommend, may go through an early menopause, premature menopause, or even a permanent menopause, and it depends on their age, where they're at as far as menopausal status, the type of treatment. And so there's, again, not a one-size-fits-all approach. It depends on all of those factors, but the type of therapy which can affect estrogen production, basically, is the main factor that plays a role. And it depends on whether we're trying to block hormones, whether chemotherapy can potentially adversely affect the ovaries and estrogen production that way. There's things that we can put into place to help smooth that transition if and when that happens, but it's sort of on a case-by-case basis as well.
Well, to paraphrase Hippocrates, as a radiation oncologist, I believe we are called to cure sometimes, relieve often, and comfort always. Our patients' grace and strength have challenged me and inspired me, and I am profoundly grateful for them.